Good afternoon and welcome to the Flint Community Webinar. The Flint Community Webinar is your community resource every Friday at noon. We're so glad that you're here. We have an amazing lineup for you. We've got some wonderful speakers who are going to talk about some really important topics in our community. So this includes Dr. Jennifer Edwards Johnson. Normally Jennifer Edwards Johnson is here with us. Hopefully she'll be able to join.
I'm right here.
Oh, she is here. We have two Jennifer Johnsons, and so I'm glad that you are here and can introduce our next speakers.
I appreciate you. Thank you. I had a technical glitch, so I appreciate you taking it off for me. Thanks, Heatherlyn. As you already said, we've got some amazing speakers. We've got Dr. Omara Young, who's going to talk to us a little bit about miscarriage and what that looks like in our community. Someone I am routinely get mixed up with and am in such great company with, Dr. Jennifer Johnson, who's going to talk to us a bunch about her research in that area. We've got LaTressa Gordon here with us and Nurse T, and Kiana Wilford's going to set us off talking about Black public media and the Black Story Summit that's coming up. We're so excited to have this wonderful guest here today. And I think we're going to start with Kiana Wilford.
Okay. Hi, everybody. I am so happy to be here. I'm going to share my screen and just go through a few slides, give you guys an introduction to Black public media and talk a little bit about the Black Media Story Summit. Does that look good to everyone?
That looks fantastic. Thank you.
Okay, great. So in November, I did a presentation for the National Organization on Arts and Health about the Black Media Story Summit and what it's all about. And so we titled it COVID and Creativity, Media's Role in Supporting Underrepresented Conversations and Communities. For those of you who don't know, Black public media has been around for a little bit over 40 years. It was established in 1979 by a woman who has recently transitioned, Mabel Haddock. And it supports the development and creativity of content creators and distributes stories about the global Black experience, which is critical and important so we have representation of everyone in media. Black public media invests in its creators and provides support and experience through our programs. One of the programs that we run is the Pitch Black program, which invites media makers to pitch for funding with key media stakeholders that are in the room. And then the other program, one of the other programs we run is the incubator program, which is a highly selective process to get media makers in with some mentorship and offer workshops. Over the years, as you can see from the slides, we have awarded over $16 million. That might be up to 17 now. And we serve about 500 or more creatives annually through our different initiatives that we have. And we've been fortunate enough to work with and support makers who've received a lot of industry recognition, as you can see there. A couple of projects received 2 Emmys in 2022 when Claude got shot, and then Unresolved. Unresolved is a multimedia AR installation, and our signature series is Afropop. And it's actually, we're starting season 15. This is an old image that's going to premiere in April on World Channel. And then a couple of years ago, we started a campaign called Be Heard, where every year we take a special topic that's important in the Black African-American community. The first year we focused on voting, and this year's campaign, we focused on gender affirmation. So I had the privilege to work with and meet Dr. Deborah Holden and establish a partnership for Black public media with the National Network to Innovate for COVID-19 and adult vaccine equity, a mouthful, so we call it NICE. And it is to explore media strategies for overcoming the problems of vaccine hesitancy among African-American and Latino communities in the United States. And one of the things that Black public media does is we host a Black Media Story Summit. The Black Media Story Summits have been around for a while, but what's amazing is that partnering with NICE, it allowed us to reshift our focus and really be have a theme. Before it was just general topics for media makers, and now it's focused on a theme that's relevant to our communities. And so we had our first Media Story Summit last year in Baltimore. And it was 100% virtual because of the new state of the world. And we have panels and case studies. We, once we review the panels and case studies, we break out into small groups and do some brainstorming and sharing with a cross section of people from the local community. So creatives, public health professionals, community organizers, thought leaders, philanthropists, and it's just to get that rigorous, diverse conversation about what we can do to create creative messaging to promote health and wellness when it comes to vaccination. And after the March Story Summit, we had an application process, and we had 10 submissions, and we awarded two filmmaking teams, Afro Chic and Fearless Video. Afro Chic did Baltimore Speaks, which is a 15-minute documentary in a traditional form. And I believe what's going to come up next, I'll show you a little clip of that.
There still isn't a COVID-19.
Audio good?
Talked about as much as it was previously. But people are dying from COVID every single day. The numbers are going up.
It was a huge uproar within the community at the time because there was a percentage of Black people who did not get the vaccinations at the time, and including me. I was one of them.
The relationship between the Black community and the health community in Baltimore is complex.
There was a fear and a common place for me to be wondering, what are we going to do to educate each other?
Because they're not doing enough for
So that was one of the projects. And they talked about, you know, why they attended a summit, why it was important to them, and kind of has a really elevated kind of like tone and perspective, academically speaking. Then the next series project that we funded, which I really enjoy and appreciate because it targets a different demographic. And it was a social media campaign, and it was done by Fearless Video, and it was called COVID Conversations. They created 4 little mini shorts, no longer than 2 to 3 minutes each episode. And here's a taste of that.
Are you vaccinated? Yes, I am.
No, I'm not. Yeah.
Not completely.
Not taking no jab.
What's going on, family? We're out here at the beautiful Lake Montebello Farmers Market in downtown Baltimore at the world famous Lexington Market, Baltimore Inner Harbor, man. We're having COVID conversations, and I'm the man on the street. Wanted to ask you, are you vaccinated?
I only got it because I feel like society forced us to do it.
Okay.
And this is for my mother's safety.
I've seen the people that didn't vaccinate, they was catching it more than people that was, you know what I mean? So, I mean, you know, when you go to the store and buy cough medicine, you don't know what's in it.
I can never find a good time to get vaccinated.
So as you can see, their 2 media makers had 2 different approaches, 2 different audiences, which I absolutely love and appreciate, because we are, as we say, we're not a monolith. And so it created a vast opportunity to approach different audiences. And in addition to this, we had, once the projects were completed, we went into Baltimore and had screened the projects and had community talkbacks, which I'm really looking forward to doing for this next edition of the Story Summit, which is actually next Friday, March 3rd. And it's going to cover 2 regions, Michigan and North Carolina. And it starts at 9:45. The doors will open, and it's going to be a great time. We will be having conversations about building bridges and reestablishing trust. We're going to have a conversation about young adults and mental health during the pandemic and what are some solutions for that. And then those folks that are in attendance will be able to hear from one of the filmmaking teams from Baltimore to learn about their process of filming during COVID and the things that they learned, and hopefully inspired the creatives that are in the room and those community organizations who want to make film projects, give them some ideas. So that is a little bit about me and Black Public Media and the Story Summit. I hope you will be able to join us.
Kiana, I love it. This is amazing. I also love it because that's my student. Asase is a Flint grad from our MSU CHM program, and she's at Hopkins doing really great things in their IM program. So shout out to her. Shout out to her. She's always been a really great creative. Have a question about how you're measuring outcomes, because you're doing super dope, really amazing work getting messages out to community. Have you gotten any really tangible feedback about where it's moved the needle?
The one thing I can say for the social media campaign, they have provided us their impressions reports and things of that nature, what they've reached, how long people stay on. Right now, I can't provide you any of the statistics because this was like back in November.
Of
but
course.
we do have that that information and that data. Yes.
Really cool. So you're getting sort of like how many people you're reaching and what you're able to reach. It strikes me that it would be neat to be able to see like, wow, people saw this, people went to these events, people learned, and you know, we saw an uptick in vaccinations, or we saw more people having those conversations.
Yeah,
really.
I know. One
Ahead.
of the things the maker said, the Baltimore team at first, the COVID conversations piece, where it was kind of like the man on the street. They were kind of, you never know, because every community is different and has its own culture, idiosyncrasies, you know, dynamics. But they were really surprised and amazed how open and forthright people were in all of the street locations that they went to, sharing what they thought was fact, what they thought was fiction, their pros and cons. Like, the series is really strong and gives you a nice snapshot of where the folks in Baltimore are at. And I'm curious to see, when we have these projects from Michigan and North Carolina, not only what the style of the films are, but what the messaging is and what the similarities and differences are.
That's really cool. Is there a different theme for the ones that are going on this week, Friday?
The theme for this Story Summit is called "It's Been 3 Years, Now What?"
I love it.
And we're going to have our keynote speaker be Santita Jackson. Yeah, so it should be a good time. Thank you, Heatherland, for putting all that information in the chat.
Absolutely. Last question. And you said Michigan and North Carolina. Where in Michigan should people be like looking out to see this?
Well, it's all completely virtual. You can go online. I think Heatherland put the links in the chat. If not, cool. I'll put the links in afterward. But it's a completely virtual event. So that's how we're able to do 2 locations at once. So one panel is going to be representative of the NNICE partners in Michigan. The other panel is representative of the NNICE partners in North Carolina. And then we have the media panel, so people can really get an idea of what can be accomplished with the funding that Black Public Media provides, thanks to the NNICE initiative.
And you say that link goes live around 9:45 for people.
Well, you can register now, but the program officially starts at 9:45. Yes, awesome. But register today.
Thank you so much for sharing all that really cool information about your programming. Super excited. Great
Thank
work.
you.
Thank you again.
Thank you.
All right, we're gonna pivot a little bit. We're gonna thank you so much to Kiana Wilford for all of her wonderful expertise. Dr. Omari Young got stuck with the patient, and we are going to pivot directly to Dr. Jennifer Johnson, who's going to talk to us a little bit about her projects. That she's going to talk about 2 projects, HeAL and Miracle, and I will give her the floor. Thank you so much for sharing your expertise with us today.
Oh, thanks so much for having me. I'm excited to talk with everyone. All right. So I wanted to talk some about some maternal health opportunities in Flint. Some of them are wider than Flint, but in 2 basic areas. The first is in the area of miscarriage, stillbirth, or death of a newborn. These experiences are more common than you might think. 1 in 4 women experience a miscarriage in their lifetime. And about, 2/3 of a million women in the US experience some kind of perinatal loss each year. So that includes, miscarriage or early fetal loss, which is less than 20 weeks. Stillbirth is typically considered sort of that over 20 weeks or the late fetal death, or a newborn that dies in the first 30 days. So, this is a lot of people having this experience, and it's somewhat under-recognized grieving. Our culture doesn't have strong norms about how to grieve a loss like this. People might have questions like, do we give the gifts back? What, if for people, sometimes people with miscarriage, mostly others don't know they were pregnant, but if for someone who was showing, they were clearly showing, and people who don't know you might very well might ask you how the baby's doing. Or people say well-intentioned but unhelpful things like, oh, you could just have another one, or maybe God wanted your baby back, or something, that people don't experience as helpful. And for a lot of these reasons, a lot of moms and their partners grieve in secret. And it's, there's more advocacy and more recognition now that parents with these losses have a right to mourn. Even if it's an early miscarriage, you were expecting to have a baby, right? And that's a loss. And your child isn't supposed to die. Sometimes women question their bodies, question if they're broken somehow. And some moms will go on to experience, mental health conditions, potentially some depression. I've been surprised as I've been doing this work how many moms have some symptoms or full disorder of post-traumatic stress disorder just from the experience itself. Sometimes they're, in pain or bleeding and they're alone, or they, can't, they're in an emergency room and can't get someone's attention and whatnot. So just the whole thing is difficult, but it's under discussed and I think under treated. And I wish Dr. Young was here. Maybe he will come back, but I think here's my analysis as psychologists. Don't take this as truth, but sometimes I wonder if OBs go into that field because they want a happy ending, that they like the happy outcome, and it can be hard when the outcome is sad. So
Jennifer, I'll say I did not go into OB because of that, right? The highs are really, really high, but the lows are so low. Like something like this is just, it was hard for me. So I have a lot of respect for OBs who are navigating this with their patients. Thank you for that point.
Yeah, it's hard. And, just even this last week, the more you do work in this field, you sort of keep hearing about it. Even just this last week, a young woman who grew up with my daughters, and they're now all in their mid-20s, was expecting a baby that they knew from ultrasound wasn't likely, may not survive birth, but the baby survived birth. Beautiful baby, so cute. Took him home, and he died 6 days later. And again, they were happy that they got the 6 days with him, but the funeral and the little tiny baby coffin, I don't know, it's really sad, right?
It's really hard.
It's hard. So While I actually, 10, 12 years ago, I was working with a therapist friend who came to us and said, she worked at an obstetric hospital, and she said, I have all these moms experiencing these losses. I can't treat them all. I'm not sure what to do with them. Can we work together to figure that out? So that started in 2008, actually. So I guess it's been almost 15 years. And we worked with several experts, put together some treatment manuals around, how to help people deal with this, the sort of things that they can talk to with their partners or other people, what's helpful, what's not helpful. And pilot tested it. And at this point, we have a project. It's funded by the National Institute of Child Health and Human Development, one of the NIH institutes, to it's a large project that's comparing like these two different interventions. They're both counseling interventions, both group-based, for depression and distress after a miscarriage, a stillbirth, or death of a newborn. And so we have free counseling basically available to women in Michigan, anywhere in Michigan. Because of COVID, we went virtual. And I think I saw some of my wonderful counselors on our attendee list that are over in the west side of Michigan. But I wanted to bring this up because I think, as we're looking at our referral sources for the project, we're not getting as many referrals from Flint and Genesee County as I think we expected we would, especially given the rates of miscarriage here. And since we're Flint based and our hearts are in Flint, we just wanted people to know that we're here. This is, like I said, this is anyone in Michigan who's lost a pregnancy or a baby in the last 18 months can be eligible for this. They can call us, email us. And if you're a provider or an agency or a, someone, we've talked to funeral homes and childcare providers, if you work with pregnant women in any way, or your pastor, if you call or text us or email us, we can also give you the brochures and whatnot and help you, know how you can refer people to us. So like I said, this is mostly, I wanted you to know about it and wanted people to know about this resource that's here. And, I'm happy to answer questions about miscarriage, stillbirth. I will say, from having treated so many folks as a psychologist, I guess I will say these two things. Almost everyone thinks it was their fault. And it's everything from, I did a certain dance move, I shouldn't have argued with my boyfriend, I shouldn't have eaten spicy food, I shouldn't have, and almost none of these things medically trigger miscarriage or stillbirth, but it's just this natural thing we want to believe we're in control. So I guess I will say this to anybody who's experienced this. It is almost, it's not your fault. There's a few things you can do, but very few things you can do. And if in doubt, talk to your doctor. And I would also say that it's okay to be sad. It's not nothing. And it's okay if you don't want to talk to people about it, or if you do want to talk to people about it. But it's okay to ask for what you need. And if you know someone who's had a loss, I would say, ask them, say, I'm sorry, how can I support you? And not assume, because it's, there's a lot of different, people have a lot of different ideas in general about how to grieve. Some people, like to take time and do it. Some people like to cry a lot. Some people, try to be strong. That people deal with it all different ways, and how you deal with it is okay. And it's okay, but people sometimes have different expectations. I had a patient that I saw who had a really traumatic birth. She almost died. The baby did die. They just put her under to save her life. And when she woke up, the baby was gone. And she went back to work, but she came to me because she was crying a lot and couldn't kind of, was struggling. I was like, no, that makes sense. That what you went through was really traumatic. But she hadn't talked to her husband about it because she thought he didn't want to talk to him about it. He didn't want to talk about it. I was like, well, why don't you just ask him? And when she did, he had bronzed the baby's booties, and he had saved like pictures and all the things. I was just sort of waiting for her to bring it up. So I guess I want to share that. And like I said, if you put it on folks' radar, support these moms, support these families. And if you know somebody or are somebody, you know, please help us get the word out. And I guess I'll stop there for questions.
Absolutely. I have one, you know, as a provider in this field, I have experienced that we educate people who become pregnant, particularly in the first 12 weeks of pregnancy, about, you know, the risk of miscarriage being higher in that first trimester, right? And so there's a little expectation setting. While it will never be an it'll never be an expectation, it'll never be something that people can wrap their heads around. There's some counseling and some education that we do with that early on. And I wonder what your experience has been in counseling with how, like, the counseling that might differ between those who suffered an early loss and a late loss, and the willingness of people to sort of ask and reach out for help in those settings.
You know, so I think it's like everything. It depends on the person, right? So, you know, I think there's sort of this idea that, you know, the later it is, the harder it is, which could be true, but it isn't always true. If somebody has been struggling for 8 years to get pregnant or 5 years to get pregnant, they get pregnant and they lose that baby. That's a big deal, right? People with repeated losses, people who, you know, have lost parents or lost other important people in their lives, this might hit them different. And so I think it's, you know, and it's interesting because you hear moms, like, sometimes the pregnancies are unplanned and they thought they were unwanted, but then when they lose the baby, then they feel like, then it's even more complicated because they feel like they did it somehow because they weren't super happy about it. And that's why they lost the pregnancy. You know, it's complicated. So I guess I just think it's a case by case, and nobody's grief over this should be discounted.
Absolutely. Thank you for making that point, because we hear that, you know, there should be that some people might grieve differently because of where and when they delivered, or when they experienced their loss. And I appreciate you emphasizing that point, that loss may be different for you across the spectrum. Are there things we should be thoughtful about saying to people who might have experienced a miscarriage that come into our lives? You know, people that we are trying to be a friend for, people we're trying to be sort of a listening ear for.
Yeah, I would say, don't say you can just have another one. Don't. Right. I mean, it seems like it should be obvious.
No, I'm so glad you said it, because it's a thing that you're appalled when you hear, right there. It is a thing that people say, and they're well-meaning, it, which doesn't always mean much, but it's true. Thank you.
Yeah, and don't say things like, you know, I've heard. You know, moms vary, or people who are pregnant vary in how outspoken they are. Sometimes you'll get someone quiet, but I have heard some who are more outspoken. When someone said, you know, maybe God just wanted your baby, say, well, why didn't God want your baby? You know, I mean, don't say stuff like that. I wouldn't try to dismiss how mom feels or how the family feels about it. I would say things like, I'm so sorry, you know, how can I help? How can I help is always a great thing to say, and then they'll almost always tell you what they need.
I appreciate that you mentioned someone who had a partner who was really struggling, and I feel like sometimes the partners who are struggling don't always feel like they have the same resources, and there's sometimes some guilt associated with that. Do you have any thoughts about that relative to the idea that there's some guilt that some people feel because maybe they weren't the person that was pregnant and, you know, independently or physically experienced the loss, but emotionally and otherwise they're still feeling that loss?
Yeah, you know, the losses, there's research shows that losses are really, really tough on romantic partnerships and marriages. They're really hard on couples. And enough, it's not given that your partnership will struggle, but, there was one study that found that on average, the couples struggled more even up to 9 years later. So it's a challenge, right? What sometimes happens is that, we all have these assumptions that we just think that's the way the world works. So what we'll have sometimes is one partner who thinks that, to honor the baby and whatnot, that, they need to grieve and they need to be very, open about it. And sometimes the other will think, well, I need to hold it together for them. And then that one, the more outwardly grieving one will think, but you don't care. And then that one will think, yeah, but, and so like people have these assumptions about the way their partner or the others around them are dealing with it, which you just, it's a simple conversation about, tell me how you feel about this. What do you need from me? Because like I said, we have these sort of assumptions about what is the right way to grieve and might put meaning on it that isn't there for someone else.
Yeah. There was a question. Thank you for that. That's, I think it's really important to recognize like what happens to the partnership there too, and how the partner in that relationship might be working through their own grief, and how additional grief might happen as a result of the strain on the partnership, right? How additional strain might cause difficulty. We had a couple of follow-up questions, and one of them was, what can women do to care for themselves after miscarriage?
Yeah, so that's a fantastic question. I love it. And I think, depending on what happens, it's a physically traumatic experience. I was thinking about our family friend who went through the whole pregnancy, is having all the postpartum physical things, and is also holding a funeral, right? Or even, a stillbirth or a miscarriage, people can lose a lot of blood. They can be in a lot of pain. And so just start with that. Just recognize that physically it can take a lot out of you. You need to sleep, you need to eat healthy food, you need to take vitamins, especially if it's after 12 weeks or even before, talk to your doctor about it. And then just emotionally recognize, well, it was really interesting. I worked in a VA hospice unit for a while I was training. And the thing I learned there that I didn't know before was it physically takes energy to grieve. And so grieving families need more sleep than usual. They need food. They need, it's emotional, but it's physical. And so again, give yourself space. And that doesn't mean, we also have a situation where a parent might think, if I go back to work, or if I laugh again, or if I do something fun, I'm not remembering my baby, or I'm disrespecting my baby somehow. And I would say, you don't have to be miserable all the time, and you don't have to hold on to the pain to hold on to the relationship with the baby. And it's okay to laugh and it's okay to smile. But, if you have to go back to work, you have to go in a situation where you have to function, you do that, but then, set aside some time at night or a few times a week to let yourself be back in that space. And there are really some nice, there's some nice advocacy organizations online, both for miscarriage and stillbirth and neonatal death. A lot of the hospitals around will have pregnancy loss, like birthday celebrations, if that's something that you want to do. But I guess I would say give yourself space, give yourself time, recognize that it might take that, but also don't feel guilty if like something happens that's funny and you laugh. It doesn't mean you didn't love your baby. It's just, like life keeps going.
I think it's so important, the parts that you mentioned about taking care of yourself, right? Because your body, in addition to sort of your what you're feeling, right? But your body has undergone an ordeal, and a lot of times there's lots of physical needs that you might have, right? You alluded to some of them. You might have blood loss. You are requiring more energy. You might be super fatigued. There might be things that you need. I super appreciate the recommendations are, one, make sure you're getting in with your doctor as needed and getting the appropriate amount of sleep, which might be more than you're used to getting, right? And taking care of yourself, eating and letting people care for you. It sounds like these resources and this counseling that's available really sort of helps people as they navigate what they might need after this experience. Should people be thoughtful about a timeline on the resources? Like, if someone discovers that they're still struggling with their loss, maybe 6 months after, can someone still access these resources? And
yeah, we take people up to 18 months.
okay.
And I would say call us, email us. Again, if you're a provider, you're somewhere where pregnant people are, we're happy to give you flyers and whatnot to hand out also. And, we're taking, we'll kind of do an evaluation. We're taking moms who really are, I would say more on the severe end of the stress. But if we're not the right fit, we'll find you someone who is. So yeah, just call us. And again, like I guess I'm repeating myself, but one thing I've been surprised by is the amount of PTSD that we see. And I won't go into the graphic detail, but a mom might wake up in a pool of blood, right? It can be it can be scary. It can be unexpected. You don't necessarily know what's going on. So just, I guess I would say, if you are someone who's had this experience, talk to your doctor, talk to someone else, call us. It almost definitely wasn't your fault. And if you know someone who is, take care of her and help them take care of themselves.
Yes. I have one more question for the chat, and I know you need to get to the next topic that you're going to talk about, your next project. And that was, you mentioned that the therapy in HeAL is often group-based, and I wondered if you'd talk a little bit about what that means and how that might be different from individual. That was a question someone asked.
Yeah, so one of the things that we found while we were doing this is that it's such a hard experience, right? And so the way the groups work, like I said, we're doing it virtually, but it's all moms who've had, a perinatal loss. That it really, we add new people every 4 weeks. The groups are small; they're maybe 6 at the most, maybe sometimes 3 or 4. But that it helps because by the time you've been in 8 or 9 weeks, you are starting to feel better, and those new moms coming in sort of see the light at the end of the tunnel, and the ones who've been there for a while can look back and say, wow, I remember being there and I'm not there now. So it's really to support each other, to learn from each other's experiences, and to see how it looks in a few weeks. It can look better, and to remember that you're not now where you used to be. So I would say, don't be afraid of the group part. And if you have questions about it, call us and we'll tell you more about it. But
fantastic. So this is, to summarize for all of you, amazing resource, HeAL. You can use the number there or the email, and it's virtual. So it meets you sort of where you're at, which is a really wonderful opportunity to access some resources. You can access this resource as long as up to 18 months after experiencing a traumatic loss. How long is this program being offered, Jennifer?
Another 3 years.
Another 3 years. That is fantastic. What a great resource to provide for people who might be struggling. Thank you so much for talking about it and providing this resource. I know you want to talk to us a little bit about another project that's really wonderful for our community.
Yeah, thank you. So again, this one relates to pregnancy and postpartum, but different topics. So yeah, so a word about HeAL. So let me tell you a little bit about, we call it Miracle. It stands for Multi-Level Intervention for Racial Equity. And this is across Genesee County and also Kent County, but I'll talk about Genesee County since we're in Genesee County. So this is a project, again, it's funded by National Institute of Minority Health and Health Disparities. I will quickly go over maternal mortality disparities, this is just a way to say that more pregnant people of color die in pregnancy and up to a year postpartum than non-Hispanic white people. And what's interesting is, that is true in hospitals, but it's true during pregnancy and it's true postpartum. So about roughly a third-ish of maternal deaths happen during pregnancy, a third-ish around, the period of childbirth, but another third or a lot, maybe 40% even after mom goes home from the hospital. And so, there's a few different reasons for this. I'll go through the causes quickly and then talk about some of the things you can do. So, I'll start with this here. It's more than individual behavior that disparities in maternal outcomes persist after controlling for patient characteristics like healthcare behaviors or in their health before conception and healthcare system factors like site and quality of care. So, the upshot is racism is a big piece of this, and a lot of it's unintentional, but it is nevertheless having really serious effects for women of color, especially African-American women and Native American women. They're 2 to 3 times more likely to die. And often there's another sort of set of conditions called, maternal morbidity or severe maternal morbidity. And these are kind of these near miss experiences, right? Where mom didn't die, but needed a transfusion or had a stroke or had some other really negative health outcome. So, at the community level, all of these things can affect maternal health. African-American women are disproportionately likely to live in neighborhoods that pose challenges to their health, have to work multiple jobs, have poor access to quality childcare in unsafe neighborhoods. But I will say, this is true. And, if you look at some of the outcomes, or if you look at, I think Serena Williams was one that did, has talked to the media. Really high income women of color also experience neglect at the hospitals. They don't get taken as seriously.
Yeah.
So at the system level, this is access to high quality care, structural racism. Hospitals serving more African-American women tend to offer lower quality care. And interestingly, you can improve quality of obstetric care at a hospital overall without making it more equal or reducing disparities. So projects really need to focus on disparities, focus quality improvements, provider and practice levels. This is the cultural competence, communication, unintended biases of the clinicians and staff, including front desk staff. I had, even in the past few weeks, I've had my staff who've been in various emergency departments in Southeast Michigan and just said that people would come in and say, I'm miscarrying, I'm in pain, I'm having a problem. And the front desk staff are just sort of like, and so those sort of attitudes and who gets taken seriously and who gets heard matters. And not surprisingly, if you get treated poorly in the healthcare system, it doesn't make you super excited to come back. And there's a lot of research, not just with pregnant moms, but just in general that has shown that controlling for patient class, health behaviors, comorbidities, health insurance, healthcare access, healthcare providers undertreat African-American patients for pain. They don't listen to African-American women about their symptoms. They blame them for their symptoms. They provide less appropriate care. They assume drug use or sexually transmitted infections versus something like endometriosis. They provide older, cheaper, more conservative treatments. They discharge African-American patients too soon and prescribe inappropriate medications. And it was like one of the, the people, the moms talking about her experience in the hospital at childbirth said, there's so much judgment. If you're too calm, then they say, oh, you're not sick, you don't look sick. And then if you're crying and moaning, they say you're exaggerating. I don't really know what they want from us. And, there's all of this, again, if you like, just even put this into YouTube, there's several stories. You'll get a lot of people's stories, but just seeing where the mom has reported really severe symptoms, or the family has said, hey, this really looks like a problem. And the hospital staff or the health system just isn't responsive. And I think I like to believe that most of this is not intentional, but I guess it's a wake-up call to to everyone that even unintentionally, there's this very clear difference across a lot of different aspects of healthcare about how African-American patients are treated. So what can you do? It's very concerning. What can we do? So there's a few things that we're doing here. Again, this project's mounted all across Genesee County. So if you're anywhere in Genesee County or anywhere in Kent County, there's a few different things. One is we have a day-long version of this that talks in detail about changes practices can make, some of the best practices around this, some of the causes, opportunities. So this is for anyone working with pregnant or postpartum people in the healthcare system. If you're staff, if you're a provider, if you're CEO, if you're a nurse, if you're anyone, if you're on, human services side, if anything you do has to do with pregnant or postpartum people, this is a free workshop. You can email Morgan here for instructions on how to register. It's a workshop we repeat, and it fills the LARA anti-bias licensing requirement. And we have CME credits. We don't have CEUs yet, and it's great because it's like I said, day long. We talk a lot about different solutions, go into them in depth, and it's taught by me, by Dr. Key, by Dr. MiCHWA, and several of our longstanding community partners, Dr. Deloney, Sharon Sadler, many people. So I wanted folks to know about this because I think it's a nice opportunity to sort of sit down and think through all these issues that are causing our moms of color to die more. We are also providing all across Genesee County and Kent County free technical assistance for offices and agencies in providing, that are providing prenatal or postnatal care in the county in evidence-based interventions that reduce maternal mortality disparities. And Dr. MiCHWA will actually come out, work with you, sort of talk about your patient flow, different things you can do. We're at the very cutting edge of the Alliance for Innovation in Maternal Health, and the community care sort of quality safety guidelines. And so, some of these, just to give you quick overview, is again to remind you, you can improve overall quality without changing disparities. So you really need to focus on disparities. Heatherlyn Uphold and I were talking before that one of the recommendations for big healthcare systems is to look at your birth outcomes, your maternal outcomes, like C-section rates, transfusion rates, different outcomes by race, and really see what's going on in your setting. And then you kind of know what you can do. Two things I wanted, like I said, if you reach out to us, we can help you set up some of these evidence-based approaches. But two, I wanted to quickly call out the Maternal Infant Health Program is Michigan. It's funded by MDHHS. It's for all people who are pregnant or postpartum who are eligible for Medicaid. And it has been shown to dramatically improve both maternal and infant outcomes. And so, we're trying to work with providers and hospital systems to make sure every eligible mom gets referred. She doesn't have to go, but gets referred into that system. And then often they'll refer to another program called Healthy Start. But these programs, reach out to mom, will visit in the home if they want, or speak to them by phone and offer some other wraparound services that support maternal and infant health. The other one I wanted to talk about, just mention, and I'll talk more about it in a minute, but CDC has a campaign called HeAL. And basically this is ideas like we really need to listen to African-American moms, Native American moms, like we need to listen to them because that's the core of the problem. But it has some nice guidelines on that website about warning signs for providers, for nurses that you can give to your patients. I will show you. So again, this is sort of more provider and agency facing side. So if you're interested in any of this, please reach out to us. We'll tell you more. But I wanted to give something to, the people and their families. So CDC, this HeAL CDC/HeAL has, like I said, nice resources for everyone, for pregnant people, postpartum people, their families, the providers, different people, areas in the provider system. But this is an example of one of the handouts that says, you know your body best. If you experience something that seems unusual, don't ignore it. Talk to people, talk to your provider. And again, remember that about 40-something% of moms who die related to pregnancy, it's after birth. So you may be home and having a problem. The bottom of the handout looks like this. It has some of the warning signs like severe headache that doesn't go away, dizziness or fainting, thoughts about harming yourself or your baby, changes in vision, high fever, swelling in your hands or face, trouble breathing, chest pain. So, right, if you're, I'm sure our Jennifer Edwards Johnson is sitting here thinking, hypertension, stroke, embolism, risk. Anyway, so a lot of these things, the baby's movement stopping or slowing down, heavy bleeding, swelling, redness, pain of your legs. So this is a nice handout that you can give to people that said, look, these are problems. And if you or someone you love is experiencing this while you're pregnant or, in those months after birth, that's a problem and they really need to reach out. And then there's a guide to help start the conversation. So I'll stop there, but all of it is to say, like I said, we have this money to work all across Genesee County. And if you're a mom, if you're somebody that is a family member, if you are a provider or interact, or if you're a healthcare system, we have ways that we can work with you to try to provide support and technical assistance and some of these best practices to reduce those disparities.
Thank you so much. You've got wonderful questions in the chat, and I appreciate you so much for being willing to answer questions with us. I know what that's like. So there's a few questions. One was, could you clarify the difference between maternal morbidity and maternal mortality? And because you mentioned some of that. So
yeah, sorry for that. So
no.
maternal mortality is mom dies before birth, during birth, after birth. Maternal morbidity is she has some health condition or bad health outcome that she doesn't die, right? So that could be, if it's severe, it could be a stroke, it could be hypertension, it could be preeclampsia, it could be needing a transfusion, it could be a lot of things, but it's not death. But the disparities are in both, and sort of not surprisingly, the more of the morbidities or those bad health outcomes you have, the more likely you are to die. So there's just disparities across the board.
I think it's such an important point. You mentioned this idea of, morbidity and mortality being more likely to happen after birth, right? And there is this thought that I've experienced with my patients that as soon as they deliver, as long as they go home with a healthy baby, they are fine. And that is terrifying for several reasons, because you said it, right? People go home and those outcomes often happen after they go home. I so appreciate you talking about headache. Make sure you're getting into that postpartum visit, that visit after you have the baby. And so many moms, so many people who have babies are used to like, I got to get the baby in for the well child visit, but they don't get themselves in for their own visit. So much postpartum blood pressure, high blood pressure is found at that 4-week follow-up, 10 persist up to 12 weeks, right? So making sure that you're keeping an eye on your symptoms, you're getting in with your doctor. Taking care of your baby often looks like taking care of yourself. So I just thought that was such an important point.
Yeah, and can I say, that their ACOG, the powers that be are now often recommending like at least a 2-week check-in because of how many people die like 2 weeks out, right? Mm-hmm. And the other thing to keep in mind is like, we talked about this, but more than the preeclampsia and all the other medical conditions put together, maternal deaths, depending on how you count them, also include suicide, partner violence, so death by homicide and death by overdose. And these put together are more than half of the maternal deaths. And so I guess just keep an eye on that too, because those things also kill moms.
I think that's such an important point. The other screening that happens, right, is a screening for maternal depression right at that visit after you've had your baby. So such important data, such important things to think about. There was a question in the chat about, do we have education classes to teach women of color about prenatal postpartum complication?
So I'll tell you what I know, and I'll tell you what I don't know. So what I do know is that for any mom who qualifies for Medicaid, I think that maternal infant health program I talked about, MiCHWA, does talk about that. We're working with the providers to try to get these HeAL materials out as a standard part of everything that they do. So I think this is a systemic improvement that healthcare systems can make to help address some of these disparities. And we are trying to work with them to do that. But if you're a healthcare system, please talk to us and we will help you do that. So it should happen. Does it always happen? No.
Absolutely. That's so super helpful. There was another question. So we've talked about postnatal health disparities, and are you seeing anything in the data that suggests like just access to care for people who are pregnant, right? Like that there's disparities there. And I bring this up because before we got on, there was a question from Nurse T that there were high rates of syphilis in pregnant patients in the community. And it strikes me that some of that is an access to care problem. It's you know, a disparity that might exist, not necessarily postpartum, but intrapartum. So
I'm sure that it does. The thing you'll hear, it's interesting if you work on the health system provider side, the ones, especially the ones who sort of aren't as far down in this journey of addressing disparities, is what you'll hear is like, oh, you know, the women of color just come in so late in their pregnancy, they come in third trimester. But, you know, what we try to work with them to say is like, if you got treated the way some of your patients get treated, you wouldn't come in till you absolutely had to either.
Yeah.
So I guess I do think some of it's access to care, but I think a lot of it is how the health system responds, because if mom comes in and is in distress and gets ignored or sent out the door, that's really a problem.
Absolutely. I thought it was really interesting because you mentioned that even if a health system works on their sort of improving quality, improving overall quality, that disparities still exist, right? And I wanted to highlight it because people often like to think about a broad approach that sort of crosses, you know, we're going to help everyone. And what you're saying, as I hear it, is this doesn't help everyone. It still creates a disparity. Could you talk a little more about that?
Yeah, and those are the findings, right? So they've done big quality improvement initiatives statewide, like a lot of, I don't want to get too technical, but anyway, California and some other states have done like big statewide quality improvement initiatives around particularly maternal and birth outcomes, and improved it overall, but not improved disparities. And I guess I would just go back to this slide that, you know, doctors, I assume mostly unintentionally, provide less good treatment to African-American patients. And like I said, I wish, you know, I think if you're interested in this, it's worth looking up Serena Williams' story or some on YouTube, because you'll hear about these very well-connected, famous, you know, even affluent African-American moms who cannot get heard when they're saying as clear as they can that something is wrong. And it's scary because they'll die. And the providers just can't hear them.
Yeah. It's terrifying. As a doctor mom, every delivery I was terrified, because it doesn't matter. It's across education, it's across socioeconomic status. It does not matter. Not that it should, but it feels like there's nothing you can do to sort of improve your outcomes. Something like HeAL strikes me as one of the only, you know, one strategy, teaching moms to be really vocal and people who are pregnant to be really vocal about their symptoms, but two, making sure providers are listening appropriately.
So that's why I see a hand up, but that's why I really hope, please come to our trainings. If you're a healthcare system, please reach out to us, because there are tools to address these issues. Anyway, so yes, reach out to us.
Yes. Could you go back to your slide?
Yes.
Go back to the flyer slide.
Oh, the flyer slide.
Yeah, I think everyone wanted to see sort of that training slide one more time. Yes, this one. amazing training resource. Everyone take one last look at this. It fulfills, if you're someone in training, it fulfills, or who is a provider, it fulfills your LARA anti-bias requirement. We all need to get that. Thank you so much, Dr. Johnson, for your time and attention today and your expertise.
And thanks so much for giving me a chance to talk about, I want to get the word out because we want to make a difference. So thank you.
Yes, absolutely. Thank you everyone for your attention and your time today. Thank you to all of our partners. We will be back next week, and a reminder about those CEUs, which is coming up. Thank you so much, and we'll see you next week.